And I'm going to welcome everybody to Montefiore. So I'm Dr. Gendlina. I'm one of the infectious disease doctors. I'm actually the chief of service for the East Campus, so Weiler. Whenever you are at Weiler, you will see me around. I also am the director of infection control program for the East Campus, and I wear a number of hats. One of them is I am effectively the sepsis queen for Montefiore. So that means that if you have any questions or issues with sepsis, or if I have any issues with sepsis, we will be speaking directly. So because I have a hard stop at 1 o'clock, I'm actually gonna go ahead and start, but definitely feel free to stop and interrupt me. And this is going to be more interactive than you may be used to over Zoom. I could hear you because I could hear all the chatter before and I hear chewing. So I'm hoping that audio should not be a problem. So without further ado, the objectives for this talk is really to describe sepsis septic shock pathway, discuss importance and mechanisms for early recognition of sepsis, identify goals of sepsis management, and really talk briefly about regulatory reporting of sepsis-related measures. Can somebody raise their hand and just confirm that you can still hear me and see slides? Excellent. Okay, perfect. So let's talk about sepsis. So can anybody define sepsis? And I usually ask this question in the beginning of your meal and everybody hides behind chewing, but I do want to give you a pause to think about how would you define sepsis and what would you say it is if you had to describe it?
It serves as a source of infection.
Good. Anyone else? So I will say that sepsis is kind of like water. It takes the shape of the container. We're very, very good at recognizing it post factum and saying, well, obviously that was sepsis, but we're really not so great at seeing it at the time that it's happening. So let's talk about impact and incidence. So 1 out of 3 patients who die in the hospital actually die from severe sepsis. Now, I recognize that this comes from billing and regulatory data, but it is still pretty profound. So 1 in 3, what is the rate of heart attacks and strokes? I will say that it's less than that. So when we talk about sepsis, we actually talk about something that's unfortunately pretty common, is a medical emergency and is frequently missed. So how do we identify sepsis? How do we know when we're looking at somebody who has sepsis? So when we're looking at patients, they will present with a variety, actually a whole spectrum of different signs and symptoms that are frequently very difficult to pin down as being specifically sepsis. But speaking very broadly, so somebody who presents with fever, shivering, or chills, extreme pain and discomfort. So this is actually frequently abdominal pain, which may or may not be related specifically to the abdominal anatomy and pathophysiology. Clammy, sweaty skins, confusion and disorientation, and actually confusion is a big one because we tend to protect our brain. So once somebody is presented with confusion, that should really be a red flag in all of your minds that, oh, something's not going right. And then shortness of breath and elevated heart rate, and those really get at the SIRS that somebody from the back, I think, already mentioned at the very beginning. So of the adults who present with sepsis, majority have a lung infection. So these are our pneumonias, but that's really only about a third of sepsis that we see. About a quarter have urinary tract infections. So again, that makes sense, right? So sepsis related to UTI, but that's only a quarter. 11% have some sort of gut infection. 11% have some sort of skin infection. But for a large majority, we don't actually always get a source. So this really serves to underline the importance and the impact of sepsis. Does anybody know who this is? Anyone?
So,
Okay, so let me tell you. So This boy's name was Rory Stanton. He was a 12-year-old boy who cut his arm playing basketball 2 days before presenting to an emergency room when he came in with fever, vomiting, and leg pain. So very healthy, completely healthy young man. This is a picture of him actually taking pilot lessons. So playing basketball, cut his arm, came to ED with fever, vomiting, leg pain. On exam in the emergency room, he was febrile to 38.8. His blood pressure was 103/50. His heart rate was 131 and respiratory rate of 22. He was noted to be lethargic. He was noted to have skin mottling, and he was noted to have an elbow laceration. His labs at the time had platelets of 117 and white count of 14.7. I think we all recognize that some of these things are not abnormal, but I think we also understand how somebody could have been lulled into the sense of thinking that, well, you know, it's slightly abnormal, but not really so far off. So his bands were 53%, and those results came back later. He was diagnosed with gastroenteritis and sent home from the emergency room with conservative management. He presented back to the emergency room next day with worsening signs and symptoms. He was admitted directly to the ICU for septic shock, and he died shortly after admission to the ICU. So Rory's parents actually did something very, very brave, and instead of sort of making a not necessarily productive things, they actually started something called the Rory Stanton's Foundation. And the goal of the foundation is really to focus on sepsis to make sure that no other kid and no other person ever dies from sepsis that we could have prevented. So where did Rory's regulations go? So on January 29, 2013, Governor Cuomo of New York announced that all hospitals of New York State would be required to adopt evidence-based protocols for early diagnosis and treatment of sepsis. This is known as Rory's regulation, and this is based on the Rory story and the initiation of the Rory Foundation that has prompted this adoption of a statewide sepsis initiative. So what goes into it? So screening and early recognition of patients with sepsis, severe sepsis, and septic shock, a process to identify and document individuals appropriate for treatment through severe sepsis protocol, and really pretty stringent guidelines that need to be in place for treatment, including early delivery of antibiotics. So all hospitals are required to train all relevant staff on the protocol. It's part of all internal quality improvement process, and everything that we do for sepsis is reportable to Department of Health. So in addition to medical education and just knowing and recognizing and hopefully being able to spot it early and treat it early, I'm here because we are required to know what's happening with sepsis, and we're required to understand protocols and manage it early. So it turns out that Rory's story is not unique, and I think we know that. A number of other states have guidelines and laws that are named or not named, but implemented to really try to manage early identification and early management of sepsis. So examples are here. So Illinois has Gabby's law. We have Rory's regulation. There is reducing sepsis mortality in Ohio. There's Think Katie First in Wisconsin. I think we're all are humbled by the fact that so many of these initiatives are named after persons. So where are we with sepsis, right? So sepsis has been in existence for as far back as we can go. Obviously, it's an infection-driven process. We know that we have tried to implement a number of regulatory and practice initiatives and practice-changing guidelines. How have we done? So we looked at data that hospitals reported. So this is clinical versus claims-based data, and it's going back between 2009 and 2014. And the answer is that we haven't really done any better. So there's some studies that show that, sepsis codes are going up, and that had to do with actually higher reimbursement for sepsis and sepsis-related diagnosis. So part of the reasons was to curb that at times inappropriate sepsis coding because of this higher reimbursement, and to really ensure that that there's enough data, and if somebody is actually billing for sepsis diagnosis, that they have put enough work and enough effort into having treated it. There are penalties associated with the sepsis diagnosis, even though there's a higher reimbursement to go with the sepsis diagnosis. But regardless of that, so looking at the clinical presentation and looking at the outcomes and the claims data and the billing codes, the bottom line is that depending on what you look at, some show that we have done better, some show that we have done worse, but overall, we really haven't made a significant impact on sepsis management over that 15-year time period. I guess that's a 5-year time period. So let's talk about sepsis. I already said that it's kind of like water. It takes the shape of the container. It can be a little bit difficult to pin down, but we do know one thing, and at the core of definition of sepsis is what?
Disseminated infection.
Exactly. So at the core of sepsis is infection. So if we don't have an infection, it's really not going to be sepsis. So, and we have examples of that, right? So what can present as sepsis that's not an infection-driven process?
Hypothermia.
I didn't hear that. Hypothermia, you said? Sorry, I heard an answer, but
I did say hypothermia.
Hypothermia, good. What else? So environmental disorders or environmentally driven disorders that are not infection mediated could present and look like sepsis but aren't. Any other examples? So heart attacks could look like sepsis but aren't. Pancreatitis most certainly looks like sepsis but is not necessarily an infection mediated process. How about traumas, right? Traumas look very much like sepsis with all the classic abnormalities that we commonly see with sepsis, but aren't sepsis-related process. And the underlying difference is you have to have an infection to call it sepsis. So if it's not an infection-mediated process, then it's not on the map. It's not on the sepsis pathway. So then, if we call it an infection-mediated, right? So we have gotten our definition in place, and we understand that this is an infection-mediated process, then we're looking at two things, right? We're looking at pathogens and we're looking at the host. And I'm not going to tell you anything that you don't already know. I'm just going to put it in a framework that sort of breaks it down, hopefully clearly. But, you know, there are pathogen-specific factors that are going to make it more or less aggressive pathogen. And there are host-specific factors that are going to make a host more or less susceptible to an infection. So the same pathogen could have minimal or no impact on somebody with a robust immune response. You know, they could have a paper cut, they could have a pathogen translocation through that paper cut. They're perfectly able to curtail and fight that infection and nothing happens, where somebody who is an immunocompromised individual and has no defenses, then even a paper cut could be fatal and lethal. So it's important for us to consider that sepsis is not just pathogen specific. So we can't say every MRSA is going to cause sepsis. It's really that marriage or that union of a pathogen and host susceptibility that's going to determine what pathway somebody takes. Okay, so I kind of said this already, but when we talk about pathogenesis of sepsis, there are a number of steps that go into it, right? So there has to be a breach of the barrier, there has to be some sort of immune response, there has to be some sort of either being able to control and not being able to control the infection, and then there has to be a step of then being able to peel back that inflammatory response versus having an uncontrolled inflammation. And I'm gonna use COVID as an example for this specific instance of pathogenesis, although I will say that COVID is not necessarily fitting into the sepsis that I want to talk about. But I do want to say that COVID is one of those things where we see pathogen, we see an inflammatory response, but then we see that completely uncontrolled inflammatory response and cytokine storm that can actually lead to death because we're unable to reach that that balance. So let's go back to somebody could be high risk for infection. That leads to an actual infection, so breach of barriers. SIRS plus infection, so some inflammatory response to that infection. Hopefully that controls the infection and inflammation is controlled. And septic shock, which most of the time is actually an inflammatory response. So a couple of other definitions of sepsis that are worth mentioning. So sepsis is defined as malignant intravascular inflammation. So going back to uncontrolled inflammatory response. So malignant uncontrolled, intravascular is blood spread mediators. And we know that, right? That's our cytokine storm. And inflammation where there's really exaggerated normal inflammatory response that's completely unable to be controlled. So it's the same thing that we already said, just a different picture. So immune system's role in sepsis, progression, resolution, and long-term outcomes. I think this was a little bit more obscure before COVID, but in the times of COVID, I think we're generally pretty clear on this, that there's dysregulated host response, there is infection, and overlap of that leads to life-threatening organ dysfunction. In the core of that is sepsis and septic shock. Any questions on this? Okay, good. So infection-mediated processes versus non-infection-mediated processes. SIRS, so we already talked about some of them. We talked about pancreatitis, trauma, burns. So whoever said hyperthermia, so hyperthermia would fall into that burns environmental stuff and others. Infection, so again, infection-mediated processes is at the core of sepsis and septic shock and the progression of sepsis. So at the overlap of SIRS and infection is where we have sepsis, severe sepsis, and septic shock. Okay, so let's talk about clinical definition. So clinically, actually turns out that it's much harder to define sepsis clinically than it was to talk about pathophysiology and sort of overall definitions. So sepsis or severe sepsis is a syndrome of life-threatening organ dysfunction due to person's dysregulated response to infection, or syndrome of physiologic, pathologic, or biochemical abnormalities induced by infection. So organ dysfunction is a consequence to infection, right? So organ dysfunction is a consequence to infection, which is in part mediated by infection directly, but usually is mediated by the inflammatory response. How is septic shock different from sepsis? Does anybody want to tackle that one?
I think it's just when you have such low blood pressure that it's hard to keep them from dying.
Good. Very good. So it's sepsis, right? So infection-mediated inflammation with basically circulatory and cellular metabolic collapse, right? So end organ dysfunction where you are required to have external things to support viability and to support life. So this is where we start. Pressors, there's this persistent hypertension requiring pressors to maintain MAP. We do see a severe tissue hyperperfusion with lactate despite adequate fluid resuscitation. So this is really basically circulatory collapse where the body is unable to support that inflammation, infection war. Okay, so let's go back to clinical stuff. So this is all very good, but when we're presented with a patient at 3 in the morning, how do we know if somebody is septic or not? So clinically, how do we know if somebody is on the sepsis pathway? How do we know?
They have a known infection and then they're starting to show signs of either hemodynamic instability or changes in their organ function.
I didn't hear very well. Speak up again.
Sure. If they have a known infection and then they're starting to show signs of hemodynamic instability or signs of organ dysfunction.
Great. So then they already have sepsis and now they're on the pathway to septic shock. That's great. But how do we put them on the sepsis map? How do we see patient and say this is somebody who is on the sepsis pathway or somebody who's not on the sepsis pathway?
Vitals.
Good. Is that enough?
Perhaps, like if their white count is increasing or decreasing depending on the patient.
Good. So I hear vitals, I hear white count.
Blood cultures,
Good. How long do blood cultures take to come back?
long time.
Long time. So it's great for us to know, and we are fabulously amazing at recognizing that somebody had sepsis when we look back, but our difficulty always lies in early recognition and seeing it at the time that we see it. Good. So blood culture is key, and we're going to come back to that. Anything else? I sort of already mentioned it.
Lactate.
Good. Lactate. So I hear lactate, I hear suspected infection, I hear white count, and I hear vitals. Anything else?
Lethargy, mental status change.
Great, right. So mental status change. Mental status change is a big deal because once we see that mental status change, we know that something is really, really not right. So let's talk about early recognition. So I've already said this probably several times, but I just want to put it on the map. So on the y-axis, we've seen progression from completely well, inoculation, breach of barrier, silent asymptomatic infection, pre-sepsis, sepsis, severe sepsis, septic shock, and death. On the x-axis is time. So clinical recognition is when we actually first encounter our patients and recognize something. The breach of barrier, the initial, can you see pointer? You can see, okay, good. So what we want to do is we want to capture patients when they're here, right? The earlier we get to them, the earlier we treat, the better they do. But we really, really have very few tools, if any, and really have no means of knowing when they're anywhere earlier before they clinically present to us. So clinical recognition, early recognition is when something, the earlier we do it, the earlier they can exit the sepsis pathway, right? So something can be done, but we usually don't see them. So let's talk about how we can, am I going in the right direction? Okay, so how can we try to capture them early on, and how can we point this yellow oval as early as possible, so at the very least when they present into our system, we don't miss it. So early recognition actually has two lines of research. Do you know what they are? What's the holy grail of sepsis? Specifically sepsis early recognition. What is it that all of us want? We want a lab test. We want one lab test that's going to definitively tell us yes or no, where we can just rely on that one test and be very, very sure that somebody has or does not have sepsis. Do we have such lab tests? Have we had candidates that try to promote themselves as being that one test? Is there anything that we're using now that maybe tries to pretend that it's the sepsis test? We'll come back to that. Okay, so there are two main lines of research. One is finding biomarkers. So interesting, this is what we really, really want, but there's really no single marker that is sufficient to identify and define sepsis. And then two is the one that you all know, and now that I have it up here, you're probably saying, well, of course, is the clinical scoring aids. So let's talk about clinical scoring aids. Does anybody know any clinical scoring aids to help us define where somebody is, whether somebody has sepsis and where?
SOFA, Q-SOFA.
Great. Anything else? I already heard it mentioned. Okay, let's look. What is this?
SOFA.
Good, and I intentionally put it up here because it's very complicated and we all know SOFA by name, but I think very few of us are really able to say this is everything that goes into SOFA. SOFA, okay, what does SOFA stand for? Anyone?
Sepsis organ function assessment.
Good, sequential sepsis-related organ failure assessment score. Now that's a mouthful. When do we use SOFA? I guess we never use SOFA. When would one use SOFA?
Have organ dysfunction and you're concerned about sepsis?
Good. Well, how easy is it to use SOFA? Is it something that you can scribble on the back of your hand and be like, well, obviously the score is 5? I'm going to say no. So when did we use SOFA? We use SOFA in the ICU because it actually takes into consideration not just one calculation, but how they're doing. And it requires a number of things that we don't usually have immediately available to us. So it's a great tool. It's a very sensitive calculation to use, not very helpful when we're first seeing a patient and need to make that at the moment on the spot assessment of whether we put them on the sepsis map or not. Okay, so what other predictive scores do we have in use that are potentially easier to use and faster to use than SOFA?
Q-SOFA.
Good. What does Q stand for?
Quick.
What did you say?
Quick.
Quick. Okay. Anything else? Can you tell me what goes into Q SOFA? Do you want me to put back up the SOFA score?
The respiratory rate, heart rate, and brain something.
Okay, so let's walk through them. So we have SOFA, Q SOFA, and SIRS. Somebody mentioned SIRS at the very beginning, and then we all use SIRS, and we don't think of SIRS as a scoring calculator, but that's exactly what it is. It's a scoring calculator for likelihood of somebody being on the sepsis pathway. So SOFA we already talked about. The full name is Sequential Sepsis-Related Organ Failure Assessment Score. Q-SOFA, you were absolutely right, is quick SOFA. SIRS is Systemic Inflammatory Response Syndrome. There are others that we don't use as frequently, but you should at least know that you've heard of them once. So there's LOS, Logistics Organ Dysfunction Score, which is very, very similar to SOFA. There's MUSE, which you should actually know exists because there's some instances that we do use it. So MUSE is Modified Early Warning Score. There's NEWS, it's not news, it's not fake or not fake news. It's NEWS stands for National Early Warning Score. So I will get back to this little note that I have here of Q-SOFA being clinical gist, but let's actually talk about what goes into them. So SOFA, I already showed you, very, very complicated, a very good score, but a little cumbersome to use. So it's score 0 to 4. It's based on PaO2 over FiO2. It's based on total platelets, Billy's, MAP, GCS, so CNS status, so mental status, and creatinine. Q-SOFA is a significantly much simplified version of that. It takes into account respiratory rate, mental status, and systolic blood pressure. SIRS is the one that we're the most familiar with, and it takes 2 or more of either fever or hypothermia, tachycardia of more than 90, respiratory rate of more than 20, or PaCO2 of less than 32, and leukocytosis or leukopenia, or more than 10% immature bands. It sounds like a lot, but I think we're probably the most comfortable and the most familiar with SIRS and how to use it. But I do want to come back to Q-SOFA. So when we look at a patient, how long does it take us to realize that they're altered and that they're tachypnic?
Too long.
How long?
Is that too long?
Not too long, right? And when we look at a patient without any of these calculators, when we look at a patient, are we good at thinking that they don't look right, something's off? How good is our clinical gestalt? You're looking at a screen and you're all thinking, and I will tell you that our clinical gestalt is actually very, very good. So all of these calculators are designed to estimate or to approximate a good clinical gestalt as much as possible. So it turns out that Q-SOFA is actually the closest we can get to a clinical gist in terms of a calculator. Because if we think about it, respiratory rate and altered mental status is something that we usually pick up in the split of a second when we take a look at a patient. Systolic blood pressure is one more step that we need to get or ask the nurses, although we could get a fairly good estimate based on their based on their pulse and how strong their pulse is. So QSOFA effectively is our clinical gestalt in how the patient is doing and whether they are really should be on the sepsis pathway or not. So then MUSE I already mentioned, so modified early warning system. These are all the things that go into MUSE. Pretty specific, a little bit complicated, a little bit cumbersome to use. Great if you have a calculator, not so good if you're trying to get an assessment of the patient. But where I was going is here. So SIRS versus QSOFA. QSOFA is our clinical gestalt. SIRS is the one that we're the most comfortable using and the most comfortable interpreting. Why do we need both, and how do we pick which one to use? I also want to point out that I haven't yet said anything that you guys don't know. I'm just putting it in perspective for you. So why do we need this? Why do we need, if we look at a patient and we have a pretty good clinical idea, why do we need a calculator to go with it, and which one would we use? So we need a calculator because a calculator, an idea of a calculator helps us to stick that definition, right? So if we just say, they don't look good, and we kind of can, in our mind, know why they don't look good, but we haven't defined it. If we put it on a definition, if we say, they don't look good and their QSOFA score is 25, that's not a real QSOFA score, but their QSOFA score is 25, we have now defined them and placed them on a sepsis map. So while we clinically have a very, very good gestalt of knowing whether somebody is sick or not, we need the calculators, and we specifically use the calculators to then say, this is why they're on the sepsis pathway. So that's our early identification. Now, which one do we use? Which one do we pick, SIRS or QSOFA? And I realize that some of it is going to be provider comfort. So you're going to use whichever one you're comfortable with, and I'm going to try to persuade you to use both. But which would you choose? And how would you make that choice? So there are actually meta-analyses that compared the two. Both are pretty simple, right? Both are fairly intuitive. How do we choose which one? So SIRS has high sensitivity, so it's best to rule out tool for clinical mortality. QSOFA has the highest specificity. So what I'm going to propose to you is, and what I'm going to suggest that you do, is use SIRS-based screening followed by QSOFA repeated sequential assessment for prognostication. So what does that mean? That means that SIRS is going to put them on the map, right? I mean, QSOFA and SIRS is what it's going to say, they're on the sepsis pathway. QSOFA is going to be your morning or every couple of hours reassessment, right? So you're going to have a sick patient and you're going to go in and out of that room a million times a day because you're worried about the patient. And every time you go in and out of that room, consciously or subconsciously, you're basically implying QSOFA or using QSOFA to assess whether they're doing better or not, just based on your clinical gist. So SIRS is the one that really is the best at putting them on or the most specific in putting them on a sepsis map. QSOFA is the one that you already probably using to see if they're getting better or worse. So this is stuff that I already said, but basically SIRS versus sepsis versus infection overlaps. So infection and sepsis are pretty close. SIRS has other reasons for why somebody could be in SIRS, and we already talked about, so pancreatitis, trauma, burns, MIs. And then if we look at QSOFA, the overlap is a little different. So there's our infection that includes sepsis in it, and then there's our QSOFA that has perhaps a smaller percentage overlap with sepsis, but once they're in the sepsis in the sepsis wedge of the Venn diagrams, then we can use QSOFA to really see how they're doing in their sepsis journey. Okay, any questions on that? Good, because I think that all of you already know this. So I'm going to walk through the next couple of slides pretty quickly because this is another thing that you already know. So QSOFA quick sepsis organ failure assessment. So we're looking at respiratory rate, systolic blood pressure, and whether they have altered mental status. And really this mainly prognosticates their risk of poor outcome. So infection and SOFA, so more than 2 of sepsis-related organ failure, and the organs that we look at is respiratory coagulopathy, CNS, right? Are they altered? Liver, renal failure, and cardiovascular. So infection plus any 2 of those is a definition of sepsis. So once they're in the sepsis, once we pin them down in the sepsis, then how far along this sepsis pathway is? Well, if we have to start pressors and if they're really having severe hypoperfusion with end organ damage, that we know by elevated lactate, that's going to be our septic shock. Again, this is a the JAMA paper that, excuse me for 1 second. This is the JAMA paper that really described the SOFA, QSOFA, and the sepsis criteria. So the one that we're supposed to be using now is SEP3. I will use SEP1 and SEP3 interchangeably and not really draw any more attention to it other than here because for regulatory requirements, turns out we're still bound by SEP1 requirements. So you know where to look, you know what you need to know. Ultimately, for management, the exact definition is less important. Okay, so let's talk about goals. So we already talked about early recognition and why early recognition is important and how is it that we do early recognition. But once we recognize sepsis, then what do we do? I mean, yes, we document to say, yes, this patient is on the sepsis pathway, but what does it mean early management? And why do we want to do early management?
It improves outcomes.
What kind of outcomes?
Yeah.
Good. We have a pretty reversible outcome, right? We want these patients to survive, and we really want to decrease mortality. So let's talk about this again. So true time zero is initial breach of barrier inoculation. We frequently don't see. Early or clinical recognition, most of the time is when we first see them or when we first think of sepsis. So this is where we imply our SIRS or QSOFA and suspected infection and really put them on the sepsis map. How do we confirm or how do we know exactly where they are in the map? So this is where our labs come in. I will talk about labs in a second, but this is our basic labs. And then we treat and then we reassess. And it's really an iterative process of doing something, reevaluating, go back to see if what we just did makes any difference, and then course correcting to make it better. Okay, so once recognized, goals of management are rapid restoration of perfusion and early administration of antibiotics. And I think by now this should make a lot of sense, right? So sepsis is an infection-mediated process. Antibiotics is what directly fights infection. So we have to give antibiotics very early on. What do we do before we give those antibiotics?
Cultures,
Good. Why do we need cultures?
so we can narrow antibiotics appropriately.
Good, so we can narrow antibiotics appropriately and so that we know what is it that we're treating. So those go hand in hand. So we recognize that it's sepsis, we have to treat it by giving antibiotics, but one step before we can give those antibiotics is we have to draw those cultures because we need to know what is it that we're treating. What else do we do when we see somebody in sepsis?
Fluid resuscitation.
Good, fluid resuscitation. So how do we know how much fluid to give?
30 cc's per kg per hour.
That's a requirement, that's correct. But how do we know if we've given enough? How do we know how to course correct? How do we even know if they really need fluids other than blood pressure?
Tachycardia can be an early warning sign.
Good. So we're giving fluids for perfusion. How do we know whether they're perfusing well or not?
Looking at their signs of end organ damage, so resolution of their altered mental status.
Cold limbs.
Good,
Improved urine output.
good. What's our number one marker of end organ hypoperfusion?
Beyond the
So that's one organ. We have other organs.
lactate.
Good, lactate, right. So we give fluids, but we measure that lactate because we need to know whether they're really hypoperfusing their organs or not. And then after we do something, what do? We reassess, right? So we check that lactate, we give them fluids, and then we check that lactate again, and we check their fluid status, and we keep going back and forth until we get that balance, until we know which direction they're going, right? Because we check that lactate, it's high, we give them fluids, we recheck the lactate. If it has come down and they're looking okay, we say, okay, we did well. And if lactate keeps going up and they're not looking so great, then we start pressors, right? So we need to have that repeat lactate. So we need to have that initial lactate to know which direction they're going and how they're going. So goals of early management: rapid restoration of perfusion and early administration of antibiotics. So like I said before, part of regulatory requirements is actually this be a protocol-based approach. A number of protocols have been debated and discussed. So there's the early goal-directed therapy, which has been shown to provide significant benefit with respect to outcome in patients with severe sepsis and septic shock when a pretty stringent protocoled approach is used. The guidelines are issued by the Surviving Sepsis Campaign group. I would imagine all of you have heard of Surviving Sepsis Campaign. So what they do is actually they come up with this protocol and guidelines of how to manage sepsis. And again, protocol use, so implementation of a protocol at an institution, and then protocol use is reportable to regulatory agencies. So we report how well, when we have a sepsis patient, how well we have implemented a protocol and how well it was followed. So Surviving Sepsis campaign, I already mentioned, it was supported by the Society of Critical Care Medicine, European Society of Intensive Care Medicine. It is not universally accepted, so my people, infectious disease, is not always in complete support of Surviving Sepsis campaign. And the reason for that is actually that the antibiotics can be too broad spectrum, and sometimes we can use something narrow, and we don't need something as broad spectrum as is recommended by Surviving Sepsis campaign. And sometimes we can actually wait for some sort of culture to come back. So example would be, you know, if we are on the fence between a viral pneumonia and a bacterial pneumonia, and we got COVID result back, and there's nothing that's really consistent with the patient having bacterial pneumonia, it's prudent for us to hold back those antibiotics. But by Surviving Sepsis campaign, we're required to give those antibiotics up front. So there's a little bit of a debate. Regardless, we are bound by the same things, right? Rapid restoration of perfusion, early administration of antibiotics. Because all of this is reportable, we're sort of bound by making that decision early. And if we think it's a bacterial mediated process, then we have to give those antibiotics early. So I'm not going to go into details of this in the interest of time, other than to say that the earlier we administer fluids, the earlier we administer antibiotics, the better survival. We already talked about protocol-based approach. I want to sort of end this section with the slide to say that early recognition, are they on this sepsis map or not? And early management is, what is early management? It's two things.
Support.
I sort of heard it, but say it again.
Antibiotics and fluid support.
Perfect. Excellent. Okay. So let's talk about regulatory stuff. So I already talked about Rory Stanton's foundation. I already talked about New York State Department of Health regulations that went in effect in 2013. CMS, the Center for Medicare and Medicaid, in 2015 implemented that hospital must adhere to specific 3 and 6 hour treatment bundles for adults only with specific components and definitions. So what are those components and definitions? So we already talked about a difference between severe sepsis and septic shock, right? So severe sepsis, I think we're okay in recognizing, and septic shock is where we have really severe organ hypoperfusion and hypotension, where we really have to initiate pressors. So let's see how that falls into our 3 and 6 hour bundles. Has anybody heard of the bundled approach and the 3 and 6 hour sepsis bundles? Okay, excellent. So let's break it down. So severe sepsis, 3 hour bundle. So within 3 hours, we have to check that lactate to know where they're on the map, do those blood cultures before antibiotics, and administer broad spectrum antibiotics because this is our early recognition and management, right? So early recognition, lactate, early management, antibiotics, but for us to know whether what we're doing makes any sense, we need to have those blood cultures. 6 hour is our reassessment. So the reason there's a bundle is to ensure that we have done that reassessment within the 6 hour time period. So in 6 hours, we repeat that lactate to see is what we've done now is making it better or worse, and if we need to course correct, and if they've now progressed to septic shock and we need to start pressors, or if we have now spun them out of the sepsis pathway and they're doing great and we can actually go to sleep. Let's talk about septic shock. So septic shock, again, severe sepsis plus hyperperfusion. So fluid resuscitation is part of our initial septic shock management, and it makes sense, right? If they're hypotensive, we give them fluids. And then 6 hour bundle is then our iterative reassessment where we say, okay, we gave them fluids. Did that help in any way? Did we now fluid overload them? So we have to go back and clinically reassess the patient that we have given fluid to. And we know this, right? This is part of our practice. We give fluid, we come back to see, did we fluid overload them? Do they need more? How are we doing? And then if they're still hypotensive, then we have to start pressors. So how does it fall out into 3 and 6 hour bundles? So again, this should be very intuitive by now. So our 3 hour bundle is rapid restoration of perfusion and early administration of antibiotics. And our 6 hour bundle is that iterative clinical reassessment. Does that make sense? So when we see a patient who we consciously or subconsciously calculated Q-sulfone and SIRS, and we think that we're going to put them on a sepsis map, what do? Well, first we take a deep breath, then what do? Blood cultures, lactate, antibiotics, maybe fluids if they're hypertensive, and then we don't go too far. We come back in an hour or two or maybe less, and we reassess and reevaluate, and we repeat that lactate to see if what we've done to them making any difference and makes it better. So let's talk about regulatory reporting very quickly. So what the outcome of what we do is mortality. And I think we said this earlier, so do they survive or do they not? How do we capture that is how well we document. So documentation, billing code, and extraction of those two is what goes to regulatory reporting. So it would be very helpful for us to, one, do what we're supposed to do, but also if there any deviation, any reason why for whatever reason, there's a delay, patient is in renal failure and we can't give them 30 cc's per hour of fluid, or patient is in cardiogenic shock and we can't give them fluid, it would be extremely helpful for us to at the very least document why we're deviating from the protocol. Okay, so in the remaining 2 minutes, I will say that in case you haven't heard, there are a number of process improvement efforts throughout Montefiore that are targeting and focusing on a number of measures. Sepsis is obviously one of them. And their campus-specific process improvement teams that are supported by the network performance group, quality improvement coaches with training, and IHI quality improvement methodology to really try to tease out, figure out, and ensure that we're identifying and managing our sepsis early. So let me tell you what supports we have in place. So in case you haven't seen, we have BPA. You all know what BPAs are, right? BPAs are those yellow pop-ups that you figure out very quickly how to disable and then frequently bypass without reading. So I would like you to at least read the sepsis BPAs. So sepsis BPAs are pretty smart in the background. They run a combination of SIRS and QSOFA and Muse criteria before they come up. And they really pop up in AD, in triage for nurses, and in ED and inpatient for providers to sort of say, hey, listen, it looks like your patient may have sepsis, consider doing something. And what is this doing something going to be? That doing something is going to then lead you to a sepsis order set, which is going to say, you know, you need to do the following things, but in case you don't remember, here's your lactate, here's your blood culture, and here are your antibiotic choices. You can just click an order so that you don't even need to remember what is it that needs to be done. And obviously our outcomes is mortality and the 3 and 6 hour bundle compliance. And the bundle elements in the bundle compliance is also reportable. So not just mortality, but how well we are complying with the sepsis protocols. So this I already said, but just as a reminder, so our identification aids, right? So early recognition and early management. So our identification aids are the BPAs that pop up and say, hey, look at me, this could be sepsis, pay attention. And then our management aids are direct linked into the sepsis order set to help you select what needs to be selected. So I think you've seen this. I'm gonna walk through them very quickly. There are these yellow pop-ups that really tell you, hey, listen, patient has SIRS. They have the following abnormal vital signs that that put them into the SIRS category. They have sepsis or they have severe sepsis. And on the very bottom, take me to the sepsis order set. So again, this is a best practice alert for inpatient providers, which is probably the one you would see more than the emergency room. And then this is the order set that is linked out from the BPAs to, most of them are pre-checked, so things that you would need are pre-checked. It also has a number of labs that are pre-checked to really say, like, you don't even need to really think about it. Blood cultures are here, lactate is here, your ABG, your basic labs of CBC, your troponins, creatinine, stuff that you need to figure out what type of infection this is, and basic labs to sort of figure out where they're on the sepsis pathway. So if you're woken up in the middle of the night by a page that says, your patient is hypertensive and a little altered, you open the chart and the first thing that comes to you is a BPA alert. You can just link directly into the order set to order what you need. And as a quick disclaimer, we do track order set utilization because, again, that's a regulatory requirement. So again, comprehensive provider sepsis pathway order set. There's severe sepsis and septic shock, but ultimately both bring you to the same place. And if you have already done everything and you have your cultures and you have your antibiotics, but they're still shocky looking, you actually have a separate sepsis septic shock fluids only order set. So you can just go in and select your fluids that are already preset at 30 mils per kg per dose to really give them that appropriately volume bolus. Okay, so I am not going to go into the prediction model because that's a little bit in a work in process. We are trying to implement machine learning to really help with this sepsis prediction model and being able to smartly suggest whether somebody has sepsis or not. I will briefly mention procalcitonin. We've seen a lot of procalcitonin talk during COVID, but we do have procalcitonin that is part of the sepsis order set. So procalcitonin is used as a marker for not specifically sepsis, but how early we can start de-escalating those antibiotics, right? So when we see procalcitonin coming down is where we can start peeling off and potentially stopping antibiotics. So one thing I will say is that procalcitonin order lives within the sepsis order set. So if you don't use it for anything else, at least get familiar with using the sepsis order set for procalcitonin testing. And in the interest of time, I will stop here and take questions. Well, I know you're not asleep because as far as I can tell, all your eyes are open.
What could have been done differently in the story of the boy Rory? What did they miss?
So they missed the completely, frankly, abnormal labs and vitals, right? He was tachycardic, he was borderline hypertensive, but he had 50% bands. And the second they saw those bands, they should have immediately said, oh my God, this is sepsis, and given him antibiotics. I mean, they knew there was a breach of barrier, right? He had a cut on his arm, so there was a barrier breach. And we know sepsis is an infection-driven process. So they should have thought. I mean, it's hard to go back and think of, you know, if patient looks good, it's hard to think of what we would have thought in the same situation. But it is important to consider that there was a breach of barrier. Okay, so I am on the intranet. My name is all over the place. Feel free to email or call or reach out in any way with any questions, anytime, anyhow, and go conquer the world. Thank you.